Welcome to the Introduction to Pharmacology. So I teach pharmacology currently in an RN program. I've been teaching it for years. And for the longest time, I would try to have my students memorize every side effect, every contraindication. And I quickly realized that they were ingesting and memorizing all this information, spitting it out on the test, and then completely forgetting it. So I created this way of pretty much grouping drug classes together and universal implications related to drug classes that act in a similar manner. And then I quickly realized that not only were they being more successful on their test, they were remembering information in later courses and in their nursing practice. So I hope you enjoy this. I've put a quick example up on the board, and please reference my pharmacology video that is already online. The one I currently have up is medications that affect blood coagulation, to see if you enjoy this method. So just to give you an example, beta blockers, ACE inhibitors, calcium channel blockers, vasodilators, and diuretics. All of these drug classes decrease a client's blood pressure. So they work similarly in the body. Yes, they do have differences, but universally, they have a lot of things in common. So on one side of your chart, I do all universal implications related to all these drug classes. For instance, of course, you have to assess a client's blood pressure prior to administering any of these medications. You would hold the medication if the client was hypotensive or their blood pressure was low. We do so much patient education related to safety on medications that drop blood pressure, like please change positions slowly. If this is the first time you're getting this drug, call for assistance when getting out of bed. Take these drugs at the same time every day. Don't double dose on these medications because it can drop your blood pressure too low. So a lot of similarities. And all those similarities, don't memorize it for every single drug class. Just think these drugs drop a client's blood pressure. So any medication that drops a client's blood pressure, we're gonna group a lot of similarities into the universal implications. And then on this side of the board, we go into specific details related to each drug class. For instance, beta blockers and calcium channel blockers. You have to check an apical pulse for 60 seconds prior to administering the medication, because both of those drug classes can decrease the heart rate or cause bradycardia. So if the heart rate goes less than 60, we would actually hold those medications. But we don't have to check an apical pulse for ACE inhibitors or, for instance, diuretics. So on this side of the board, we go more specific into the differences of each drug class. And that way we just have a better general understanding of the drug classes and how they act. So again, please reference the video I currently have up to see it in detail, to see me actually writing everything down and discussing the universal implications versus the differences between each drug class. And a couple things to remember. The NCLEX only tests on generic names. So we need to know generic names. So every drug I list on any of my pharmacology videos will only be by the generic name. So if you only know it as Coumadin instead of Warfarin, you're gonna have to start to change that way of thinking, because you will have to learn generic names. The other thing I want you to take into consideration is, in the pharmacology class, how does your instructor test? Are they very big on side effects? Are they very big on contraindications? You need to take the resource that your instructor gives you, whether it be PowerPoints or lecture notes, and you need to take the generalized charts I create and make them more detailed to facilitate success on your nursing school test. Because remember, the teacher of your course is always your primary resource. I'm just in addition to their instruction. So please take that resource and fill in any additional information that you might need to help better be successful on your test. And this is also a great resource if you're at the end of your nursing program for NCLEX prep. You cannot memorize every single drug. You need to have a good understanding of the general implications of a lot of drug classes, and especially your big hitter drugs. I mean, digoxin is always a big hitter. Nitroglycerin is always a big hitter. So if you are at the end and want to use my videos for NCLEX prep, that would be wonderful as well. So I hope you enjoyed this. Again, you will start seeing a lot more pharmacology videos pop up on my YouTube page. So as nurses, we are better together. If you enjoy this method and it's helping you be successful, please let another nursing student know. All right, have a great day. Welcome to medications that affect blood coagulation. If you have not already seen my introduction video to pharmacology, please do so you better understand how I like to break down drug classes for students. Also, another point to remember is all drugs need to be listed in generic names. Those are the names you need to learn because those are the names that will be on the NCLEX. So let's start. The 3 drug classes we're going to learn about right now are antiplatelets, anticoagulants, and thrombolytics. All of these drugs affect blood coagulation in some way. They can influence further clot development. They can prevent clot formation, or maybe if we have a current clot, it can help target that clot that already exists. So universally, for all 3 drug classes, you are going to remember these things. It doesn't matter if it's antiplatelets, anticoagulants, or thrombolytics. This is universal for all 3 drug classes, so just stick it in your brain. If you're a visual learner, I like to color code things. So in black, you will remember universal for all drug classes. Green, you can think of antiplatelets. Blue, you can think of anticoagulants. I think I put thrombolytics in green as well, but let's say if I had red, you would color code it in red, so it better helps you as a visual learner. So universally, for every single one, you will monitor for bleeding. So I listed a lot of medical terminology, and a thing to do in pharmacology, you have to understand what a medical term is. You can't just think that your instructor is just going to list it on your exam. You need to understand what it is, so if it comes up in a different form, you can identify it. So hemorrhage, hematuria, so blood in the urine. Pretty much with any of these drug classes, you need to look for blood anywhere. Urine, stool, emesis, or vomit. You need to look for nosebleed. You need to look for bleeding gums. All of these drug classes put all clients at a higher risk of bleed. So that's the number one thing to do, is to assess for bleed. So again, hemorrhage, hematuria, hematemesis, blood and vomit. Hematuria is blood and stool. Epistasis, nosebleed. Ecchymosis is bruising of the skin. There's a lot more signs that could indicate bleed. A hematoma, petechiae, little ruptured blood vessels of your skin. So look at the notes that your instructor gave, and any medical terminology that indicates bleeding, add it to your chart, okay? So you need to monitor for signs of bleed because all 3 drug classes put a client at a higher risk of bleed. How else can we monitor for bleed? We need to look at a complete blood count, or you need to monitor the CBC. So when we draw this blood level, the 3 values that really show us if a client is bleeding is hemoglobin, hematocrit, and platelets. You need to know your normal values, and if they are low, we need to be concerned about that either this client is already bleeding or now we are putting them at a much higher risk to bleed. Look at vital signs. What vital signs show that a client is bleeding? Well, if we are bleeding, we're losing blood volume. So the blood pressure goes down, and your heart tries to cope by circulating whatever fluid we have left much faster. So when you're looking for bleed and vital signs, you are looking for low blood pressure or hypotension and increased heart rate, which is tachycardia. Contraindications to giving any of these drug classes. So you see my little circle with a slash through it. I want you to think of that as contraindications. If a client is actively bleeding, we should not be giving these medications to them. If they have any blood dyscrasia or any reasons why they might have difficulty with components in their blood already. For instance, there's certain cancers that target the blood. What if they already have anemia and we're giving them medications? What if they already have a low platelet count, thrombocytopenia for any reason? These medications would exacerbate those problems. We need to look for liver and kidney disease. Liver and kidneys are essential organs in all medications because your liver metabolizes the medication and your kidneys help excrete the leftover waste out. So these, all 3 drug classes can greatly influence a client with liver and kidney disease. For instance, liver disease, they might not be able to metabolize that drug effectively, and they can create toxic levels of that drug in their body. And then we like to think about clients with ulcers because ulcers are prone to bleeding. So if they already currently have an ulcer and we add on these medications, we can increase that risk of that ulcer to bleed. And then let's think of just general overall, again, universal implications for all three drug classes. If we can administer any of these medications in an injection form, for instance, anticoagulants, your Anoxiparin and your Heparin, we can give subcutaneously. Anytime we give any of these medications in an injectable form that goes into the skin, you do not need to aspirate, meaning you do not need to pull back on that plunger. And then once you inject the medication into the skin, we should not be rubbing these injection sites, okay? That is universal for all medications. Majority of these medications we have to stop prior to procedures and surgery because we know these drugs are influencing blood coagulation, meaning that these clients are at a higher risk of bleed. So we need to stop them prior to surgery or invasive procedures because they already having these procedures or surgeries done increase their risk of bleed. I do want to make a little note that of course there's always some instances that do not meet this rule. Stents, for instance, or mechanical heart valves, these clients are educated to always stay on whatever medication that is helping prevent them from throwing a clot. So they definitely have to talk to their doctors about whether not to stop or continue these medications. And then the last thing is patient education. I didn't have enough room to list all this information out, but I do want you to take notes on this. Because any client on these medications, a big thing with pharmacology is what are we to educate them on when they go home on these medications. So of course, any client on these medications, we need to educate on signs and symptoms of bleeding and to monitor for that, and of course to avoid things that put the client at a higher risk of bleed. So any client going home on these medications, they need to be educated on please prevent falls. If they already use assistive devices or have problems with their mobility, they need to be extra careful. We need to educate these clients not to do contact sports. We need to educate these clients to use an electric razor only. We don't want them using a straight blade because if they nick themselves, it might be a lot harder to stop the bleeding. Other things we need to educate on is anything rectally. You actually have blood vessels near your rectum that if we interfere with could start to bleed, especially on these medications. So we want to avoid any rectal medications like suppositories or enemas. We don't even want them straining with bowel movements. So if need be, they need to take stool softeners if they have difficulty defecating. And then also we want to avoid rectal temperatures, okay? These are all just general home safety guidelines. Individuals that are on these medications don't need to be walking around barefoot because if they step on something and cut their feet, it might be hard to control that bleed. They need to constantly assess their skin to identify any cuts, sores, or bruises. They need to keep their fingernails trimmed short and clean so we don't have overgrown nails that could potentially cut the skin. So just anything that could exacerbate or cause bleeding, we need to avoid it. So that is a lot of home safety implications. Let's think about in the hospital, what additional things we might need to do for clients that are on these medications. So we've already talked about the need to monitor for signs and symptoms of bleeding. Of course, vital signs to identify, maybe we can't physically see on the outside a bleed, but let's say they have an internal GI bleed, gastrointestinal bleed. If their blood pressure starts to go low, their heart rate starts to go high, we might need to look into sources of bleed. And again, you're monitoring the lab values of these clients. Well, other things we need to think about is caution with invasive procedures. Let's avoid unnecessary venipuncture. So let's avoid unnecessary sticking them with needles. If we do have to stick them with needles, because of course we need lab values, you need to make sure to put a lot more pressure additional time when we are holding pressure to prevent bleed from these sites. We like to avoid, if possible, IM injections because they're much deeper. Remember, they go into the muscle, so they're a higher risk to cause the client to bleed from that injection site. So those are other things we would think about in terms of our nursing care for caring for clients on these medications. So that is universal. You need to remember that for all 3 drug classes. You need to take your instructor's PowerPoints and any more detailed information they give you that you see that is universal in each drug class, add it to that side of the column, okay? And then also the resource that your instructor gives, if it needs to be more detailed, just see how the first test goes or see how your instructor tests. You need to add in information that is not here according to your PowerPoint or whatever resource that your instructor gives you. So the next thing we're going to talk about is antiplatelets. So I have listed the most common antiplatelets we administer, but again, if your instructor is listing more names on your PowerPoints or speaker notes, whatever resource they give you, list them out as well so you remember them. So very common is aspirin and clopidogrel. Yes, aspirin, a lot of people, of course it falls under an NSAID category, but aspirin can increase your risk for bleeding, so it does fall under an antiplatelet category as well. So everything over here pertains to antiplatelets, so I'm not going to relist it. You just need to understand it as a common for all 3 drug classes. Something that is a little different is the indication for antiplatelets. A lot of times antiplatelets are given for prophylaxis of long-term complications. For instance, you hear a lot of individuals taking a baby aspirin, 81 milligrams, or maybe even 325 milligrams of aspirin for heart health every day. That is a prophylaxis of preventing or trying to prevent cardiovascular disease. Or let's say a client had an ischemic stroke. Well, they had a clot in their brain that reduced the oxygen blood flow to the brain. So after they have an ischemic stroke, they are always placed on an aspirin regimen to try to prevent another stroke from occurring. And with your antiplatelets, a lot of times you can see these given in conjunction with your anticoagulants. Typically, we do not putting like with like in the NCLEX perfect world. For instance, if somebody is on 2 antidepressants, it might cause more sedation. But in this NCLEX perfect world, of course, it is appropriate to give maybe an aspirin with your warfarin, okay? So let's move down to anticoagulants. So again, universally, everything applies for anticoagulants. They have a slightly different indication than your antiplatelets. We can give anticoagulants, the most common I have listed, for myocardial infarction or heart attack, for atrial fibrillation, DVT, PE, or mechanical heart valves. So your deep vein thrombosis and your pulmonary embolism, these are active clots that clients have in your body. So we would prescribe an anticoagulant to try to help resolve this clot development. So I have listed the most common anticoagulants that we give. Of course, if your instructor adds more, please add it to the chart. But again, universally, everything applies on that side of the chart, but I'm going to go into specifics about each drug that we need to understand. So Anoxiparin is the first one I have listed. It is an injection form only. It is a subcutaneous injection. What we need to understand about Anoxiparin is we are to only give this injection in the abdomen in a subcutaneous form, so anywhere from a 45-degree to a 90-degree angle. And we are to inject the air bubble that comes in this prepackaged syringe. I have seen a lot of times nurses flicking the air bubbles and removing the air bubble prior to injection. This drug is created with the air bubble, and we are to inject this air bubble when we administer it subcutaneously. Your antidote, very similar to heparin, is protamine sulfate if these clients are getting Anoxiparin. And of course, you'd be monitoring their lab values, you'd be monitoring their vital signs, you look for signs and symptoms of bleeding. Everything pertains to Anoxiparin on that left side of the board. I'm sorry, my left side, your right side of the board. So let's move down to heparin. Heparin can be administered both subcutaneous and intravenously. How I've always seen heparin administered, if it's subcutaneous, it's more of a prophylaxis. So clients that come into the hospitals now are put on VTE prophylaxis. So that means we know clients sit in bed a lot longer in the hospitals and therefore are much higher risk of developing blood clots related to their immobility. So a lot of clients that come into healthcare, if they don't have an active bleed or any contraindication, we might start them on subcutaneous heparin. And again, subcutaneous heparin should be given, the best place to administer it is the abdomen. Again, 45 to 90 degree angle. There's no air bubble in this injection, so we don't have to inject the air bubble. But again, universally, when you inject it, you don't aspirate this medication and you don't rub the injection site. So there is a specific lab value that we monitor related to heparin dosing, especially heparin intravenously. If we have to put a client on a heparin drip, they have an active clot, they have a problem. And the way we dose this medication is based upon the APTT value. So if you've ever done dosage calculations, a lot of times y'all have to calculate heparin infusion drips boluses and the constant infusion rate in mLs per hour. So our normal APTT for healthy individuals or individuals not on meds that affect blood coagulation is 30 to 40 seconds. Your goal for heparin therapy is for your APTT value to be 1.5 to 2.5 times higher than whatever their normal range is. Mind you, we do have high dose protocols. Any client can be unique and different, so they might not fit this exact criteria. But in general, if you see an APTT value less than 60 seconds, we might need to increase the dose that we're giving this client of heparin intravenously. If you see an APTT greater than 90 seconds, you may need to decrease the dose of heparin that we're administering to this client. Remember, every resource is slightly different, and in real practice, we have heparin protocols that tell us exactly what to do in terms of adjusting doses, and they're all based upon clients' weights. But APTT values are essential to monitor for clients on heparin intravenously, because this is what we use to dose the amount of medication given to this client. So know your APTT values. We need to monitor for heparin-induced thrombocytopenia. The short name for that is HIT. So heparin-induced thrombocytopenia, that means we have started to administer heparin. And if you were to look at the client's platelet counts every day, you will see a dramatic drop, because the heparin is inducing thrombocytopenia, and thrombocytopenia's medical definition is low platelet counts. So if we are to see this, a lot of times we stop them from their heparin therapy. And remember, people on heparin IV typically have an active blood clot, and we might need to put them on another medication that will not cause HIT. So monitor for HIT. Your antidote for heparin is protamine sulfate as well. And again, universally, the whole time you're doing all this over here. Monitoring labs, vital signs, looking for signs and symptoms of bleeding, protecting those clients. Now we get to warfarin. Warfarin is available in oral form only. And what you need to understand about warfarin, it has a very, very long half-life. Meaning it takes a long time for warfarin to get in your body and become therapeutic, and also takes a long time for the heparin for the warfarin to get out of your body. So warfarin, the lab values we look at in terms of dosing or therapeutic levels is PT and INR, specifically your INR level. Your goal INR level for clients on warfarin therapy is between 2 to 3. So let's talk about this. You have a dose of 5 milligrams of warfarin due at 1700, and you get an INR level of 2.9. Do you hold it? Do you give the dose, or do you call the doctor? If it's 2.9 It is not greater than 3. We are to still administer that dose because remember, warfarin takes a long time to build up and become therapeutic in the body. Well, we have to keep administering this medication to maintain that therapeutic level. So if your INR level it becomes greater than 3, that is when you warrant holding your dose of warfarin. Not only do you need to hold your dose of warfarin, you need to monitor your client for signs and symptoms of bleeding, which you should already be doing because now we're at a higher than therapeutic level. So we're dramatically increasing the risk of bleed. Other things we need to know about warfarin, we typically can give warfarin in a bridge therapy. Remember, it takes so long for warfarin to become therapeutic in your body. So a lot of times we will administer warfarin with another anticoagulant, such as heparin IV, because heparin IV will help boost those therapeutic levels of warfarin quicker, getting us to a therapeutic INR level that we want. So it's called bridge therapy. So we would be giving them warfarin orally on top of administering heparin IV to try to get that INR level in between 2 to 3 a lot quicker than what warfarin can do on its own. Because remember, these clients on warfarin therapy could potentially, let's say they had a blood clot in their left leg. Well, we can't wait forever for that warfarin to get therapeutic. We need the medication to start working quickly. So that is what bridge therapy is. Your antidote for warfarin is vitamin K. So when we start clients on warfarin therapy and when they go home, we educate them, please be mindful, do not eat foods that are high in vitamin K because that's the reversal. So the warfarin's trying to become therapeutic and we're ingesting a lot of vitamin K foods, it is counteracting what the warfarin is trying to do. So we always think about spinach with high vitamin K foods. Also think about broccoli, green beans, your legumes. All of these food groups are high in vitamin K. And we have newer drugs in your anticoagulants that I'm sure you see commercials about all the time. These are the drugs that do not require lab monitoring, meaning somebody on warfarin has to go get their lab drawn constantly, or they now have the capability to draw it at home with certain devices to check their INR levels because that determines dosing of warfarin. But clients on these newer drugs, so you gotta excuse my pronunciation, Dabigatran, Rivaroxaban, and Apixaban. If you've heard commercials, you might have heard of Pradaxa, Eliquis, and Xarelto. These are all the newer line drugs. And why clients enjoy these drugs more so than maybe warfarin or Anoxiparin is that they don't have to have constant lab monitoring. So again, drugs that are newer line, we are giving them constantly as nurses. Anytime you see these drugs, you still better be thinking to look for signs and symptoms of bleed, making sure to protect the clients while they're at home and things like that. So let's flip to the last drug class. And again, if you are a visual learner, I recommend writing this last drug class in a different color. I had red, but red is a little hard for you all to see via the camera videos. So I wrote my thrombolytic drug class in green again, but please color code if you're a visual learner. So thrombolytic drugs, I want you to think as the clot busters. I like to think of these drugs as we are giving in emergency situations. So common thrombolytic drugs is your tissue plasminogen activator, or TPA, Adaplase, and streptokinase. We give these, our indications for these drugs, myocardial infarction, so heart attack, meaning they have an active clot that is obstructing maybe multiple coronary arteries, so we have to help them very quickly. A pulmonary embolism we know is a clot in our lung, and an acute ischemic stroke. So they have a clot in their brain that is preventing oxygen from getting to their brain. That's called an acute ischemic stroke. We are not talking about hemorrhagic strokes. Hemorrhagic strokes would be contraindicated for this therapy. So I added some additional contraindications. These drugs are high risk for development of bleed in clients, not just an active bleed maybe in their GI tract or maybe from their gums. They can create intracranial bleeding. And we know intracranial bleeding can lead to increased intracranial pressure and severe neurological deficits. So these are very high-risk medications. So additional contraindications, and mind you, any facility you work at, there will be a long list of things that will determine if a patient is a candidate for these type of medications. So other things we need to consider, have they had recent surgery? If they had recent surgery and we give them these medications, there's a high risk that they can start bleeding. If they have history of hemorrhagic strokes, they're already at an increase for another hemorrhagic stroke, so we don't want to give them a medication that would cause a bleed on the brain. Or if they have uncontrolled hypertension. And again, as a nurse, if you are to ever administer these medications, there's a long list of information you would be checking off to ensure that they are a candidate for this type of drug. So add any additional contraindications that your instructor gives you. An additional side effect besides bleed that I added was dysrhythmias. Any client on these medications would be on a heart monitor. They can cause abnormal heart rhythms, so we'd have to constantly monitor for any abnormal rhythm development. And again, does the client meet the criteria? It is based upon facility policy and best practice, a long list of items that we'd have to ensure for the client to get these medications. But something else we need to think about, these meds need to be given within a certain time frame. If you ever work in the emergency department and a client that has a CT scan shows an ischemic stroke, we need to know the last time of the known well, meaning we need to know exactly when these symptoms started to occur, because these medications can only be given in a certain time frame. So there's always a time frame attributed to these drugs. We would always draw baseline laboratory values as CBC and coagulation studies, because if they already have signs that are showing, let's say for some reason their INR is 4, they are high risk of bleed. They're probably not going to be a candidate for these drugs. So make sure your client meets the criteria. We have to monitor their vital signs. These clients are not going to a medical surgical unit. They are going to critical care, because this is a high risk drug that has a lot of complications. So monitor their vital signs. We've already talked about the need for continuous cardiac monitoring. We need to be assessing their neurological status. If they start to have a change in behavior or slurred speech, we are concerned that these drugs potentially could have affected their intracranial pressure, maybe by causing a bleed. You need to, again, we talked about sending them to critical care, and even more so client safety with these medications than just your typical put more pressure when we are doing venipunctures. In the first 24 hours after receiving these thrombolytic drugs, these clients cannot get any other medication that affects blood coagulation. So let's say a ischemic stroke client got streptokinase for a ischemic stroke at 1500 on 3-1. They cannot get any other drugs, not even a baby aspirin, until 24 hours later. So we need to protect them from adding drugs that would affect blood coagulation in those first 24 hours. You will avoid invasive procedures if you can. We should not be sending them to get colonoscopies or endoscopies, or even put an NG tube down if you can avoid it, because again, it's high risk for bleed. We need to avoid megs, we already talked about, that affect coagulation for the first 24 hours. You need to avoid unnecessary venipuncture. So of course, we have to get some lab draws. Hopefully they'll have invasive lines, such as a central line or a PICC line, that you can draw lab values from it, so we don't have to be sticking them with needles, but try to avoid unnecessary venipuncture. If you do have to stick them with any needles, we need to be holding pressure for a very long time to try to prevent bleed at that site. We need to handle these clients with care. You need to be very careful with moving them or transferring them from, let's say, the stretcher to the bed. So protect them. We don't want them hitting their elbow or tearing their skin in any way. Protect them from friction and shear if you are sliding a client over, because any little cut, any tear can cause excessive bleeding in clients that have received thrombolytics. Again, if we see any signs or symptoms of bleeding, Universally with any medication, especially with thrombolytics, we would discontinue this medication therapy. And in each facility, there are policies and procedures in terms of bleeding treatment guidelines. What we are to do if somebody on thrombolytic therapy does develop a bleed. We can give antidotes such as anticoagulants acid. If their platelet count is real low, we can administer platelets. Just follow your bleeding treatment guidelines. So I hope this has helped y'all. Again, remember all the universals related to all 3 drug classes. Take those instructors' notes and add in any details that I'm missing. This is just a very big, broad overview of these 3 drug classes, and this is really great for NCLEX prep because remember, you cannot memorize every single drug for the NCLEX. You need to group it together as much as you can and just remember universals. All right, well, again, as nurses, we are better together. Have a wonderful day.